Ending pediatric mother-to-child HIV transmission has been a struggle for the country, though the government, through the Ministry of Health, is hopeful of ending new HIV infections among children by 2027. My name is Belden Waliaula, and on this week's episode of Health Watch, we look deeper into challenges making it difficult to end mother-to-child HIV transmission. Jackie, not her real name, was born with HIV. She's now 24 years and a mother of two. She says her childhood was not all rosy. Being the only child taking medication among her peers made her question herself.
Toka nikiwa hivyo, nilizaliwa hivyo, although sikupata wazazi, sikupata siblings zangu, ni mimi peke yangu. It was difficult. The time niliambiwa, ile siku niliambiwa, sasa nilikuwa nashangaa hizi dawa napewa na wengine hawakunywi ni za nini.
News about her status was broken to her while she was in class 6, but she was encouraged after realizing that she was not alone in this journey.
Nilikuwa tu unasumbua tu, unapewa unatupa, saa zingine unaziweka tu kwa choo. Usiku anataka kukunywa, afika pale nasema nataka kujiua. Hiyo si kawaida, wengine wako sawa na mimi si yuko sawa. Nilijikubali tu. Sasa ukaanza kuona unapewa, naona mtu mwingine unapewa seminar, watu wengine wanakuambia wao wameishi hivyo, wako na familia. Unapatana na watu wawili watatu, unapata sasa nguvu ya unajipewa nguvu hata wewe.
After completing her secondary education, she had no means to further her studies. Instead, she opted for marriage, but the fear of disclosing her status to her partner often lingered.
Nilimwambia nikienda kupata mtoto, nikiwa nimebakisha almost juu nilichelewa clinic. Nilienda clinic nikiwa na 8 months. Hapo ndo sasa aliitwa, akaambiwa. Ilikuwa difficult kwa yeye kukubali. Lakini obvious alinyamaza tu almost for 1 month. Tena akaniitikia.
Luckily, her partner turned out negative and was immediately put on pre-exposure prophylaxis or PrEP as she took her antiretrovirals. Now they live as a discordant couple. She says motherhood has not been easy.
Jana imekuwa kali, lakini imekuwa kali juu kulea mtoto, huwezi peleka mtoto kwa mtu. Ukae na yeye for the 6 months, astahili kukula, kukunywa, kupewa chochote hata maji. Wewe mwenyewe ukose kwenda kazi, ukae na mtoto wako. Ama mzee unasikia hatakangi watu wako wajue. Unakaa sasa kwa plot kwa na mtoto wako, aende atafute. Anaweza enda atafute alete ama akose akikunywa.
She's now waiting for her youngest daughter to turn 2 years before undertaking the last test that might declare the baby HIV negative.
Nikienda clinic, unastahili kwenda yako na mtoto. Na kuna venye tu naenda, kuna vipimo zenye watapima. Mkubwa atumi. Huyo ako sawa. Mdogo ndo anatumia sai.
She says this will be a reprieve. All that she wanted was for her children to grow up HIV negative. Currently in Kenya, 68,000 children below 14 years are living with HIV. Over 88,000 adolescents between 10 to 19 years are living with the condition. A further 145,142 youths and young adults between 15 to 24 years are also affected. Among the population, 57,867, which is 85% of children living with HIV between 0 to 14 years, are on antiretroviral treatment. So far, 74% of children between 0 to 14 years have achieved viral suppression. The same applies to 90% of minors aged 15 years and above.
We have made significant progress in controlling the HIV epidemic, especially amongst adults. And we are subscribing to the UNAIDS standards that says HIV epidemic control, or for HIV epidemic control, that requires that 95% of all people living with HIV should know their status. These are the UNAIDS standards for HIV epidemic control. 95% of all people living with HIV should be diagnosed, and the 95% of all people living with HIV should be on treatment, and 95% of people living with HIV should be virally suppressed. Now, for the adults, we are at 95, 95, 90. And we are saying we should be at 95, 95, 95. And for children, we are at 85, 85, 74.
Kenya has made major strides in ending AIDS by 2030. The only challenge remaining is eliminating mother-to-child transmission. As of 2022, transmission rate remained at 8.6%. Yet the World Health Organization recommends that HIV mother-to-child transmission should be below 5%.
There has been a reduction in new infections amongst children by 34% over the last 3 years, and by 47% amongst those 10 to 19, and 49% amongst those aged 15 to 24, respectively, over the last 3 years. Viral suppression has improved from 66% amongst the children aged 0 to 14 just 3 years ago to about 74% currently. We have also seen a reduction in AIDS-related deaths from a staggering 14,000 children per year in 2010 to about 2,300 currently.
One of the biggest challenges that hampers the reduction of mother-to-child transmission is mothers failing to attend their routine antenatal visits and not receiving antiretroviral therapy during pregnancy or breastfeeding. Another one is a mother stopping antiretroviral treatments during pregnancy or breastfeeding, or one acquiring HIV while pregnant or breastfeeding, with another being on antiretroviral but has not achieved viral suppression. Poor availability of suitable dosage forms for children is another challenge.
Discrimination, non-disclosure to partners really drive poor ART adherence or ART discontinuation in populations of pregnant and breastfeeding women. And therefore that focused support, that peer-based community facility support is still really required, even when our mothers are linked to ART, to make sure that they are retained in care and that they take their treatment. We still have challenges with regard to case identification for our children who are outside the 2-year age group. So case identification still needs strengthening so that we can identify older children who are living with HIV. Other challenges that remain are suboptimal viral load suppression and AIDS-related mortality, specifically in the pediatric population.
We have got mothers in our communities who come for the ANC clinics very late. Ideally, once a mother gets to know that they are pregnant, they should start their antenatal clinics. But you find there are mothers who will sit and wait until the very last period. The very last days is when they are presenting themselves to the healthcare facility, and upon testing them, you find that they're HIV positive. That means that the interventions will be done late. You will put them on ART, but this should have happened much earlier, starting them on ART early so that they achieve viral suppression. So that is one of the challenges that we find. We also have women who will not present to the healthcare facility even during their pregnancy. They will probably come during delivery, in the maternity. That is when we will identify them as HIV positive, or even much later in the postnatal period when they bring their children for immunization. And that again is a late intervention because probably there's already disease progression with the mother, and she has this chance that she has already transmitted the virus to her baby, either during the breastfeeding period or when pregnant. You find that as much as we want to have these women in the program for 2 years and even beyond, there are various factors that come into play, and for one reason or another, a mother will default treatment. And for this period that they interrupt treatment, then there's a chance that they will pass an infection to the child. And there are so many things that would lead them to have an interruption in treatment. Probably they have not disclosed the status, their HIV status to their sexual partners, their spouses probably, socioeconomic factors sometimes. As much as we have very many health facilities across the county, you still find there are women who cannot even afford transport to the health facility. Fatigue. Those who have taken drugs for a long time sometimes are just tired and feel like they want to take a holiday. And unfortunately, when you're on a drug holiday, the virus does not stop multiplying. So that gives us a chance, gives the virus a chance to, just multiply and pass to the child.
Kenya aims to end AIDS among children by 2027. The country has an ambitious, accelerated plan to achieve this after signing the Global Alliance to End Pediatric AIDS by 2030. With the plan underway, data by NASCOP says 12 children are infected with HIV every day. Yet there are counties that have managed to lower mother-to-child transmission to below 5%. Counties like Siaya, Homa Bay, Migori, and Taita Taveta have the lowest mother-to-child transmission.
HIV/AIDS profile, Kiambu County is at 5.5% in terms of elimination of mother-to-child transmission. Nationally, we are at 8.7%, so you can see that Kiambu is a little bit less than what the country transmission rates show. And these are concerted efforts from the partners and even from the county government, whom we closely work with.
That's not all. 6 children die due to HIV/AIDS every day, with most infant deaths being attributed to pneumonia, malaria, malnutrition, and sepsis.
There's the issue of orphanhood, whether single parent or both parents. And we know that for children, even those exposed to HIV and don't have HIV, whose biological mother has died, are at an increased risk for mortality. We still grapple with food insecurity and malnutrition. Malnutrition drives a quarter of AIDS-related deaths among children. We still have poor access to health facilities and services, and closely linked to this is geographical inequalities. That whatever we see as a HIV response in our cities is not the same in some of our arid and semi-arid lands.
Kenya's action plan to end AIDS in children by 2027 call to action is for timely initiation and support for HIV treatment for pregnant women living with HIV, as it will reduce mother-to-child transmission. Also, timely testing and treatment of children who are HIV infected are critical to prevent them from deteriorating to AIDS and dying.
In our health facilities across the county, various health facilities across the county, where we have mothers coming to seek for health services, particularly pregnant mothers and breastfeeding mothers, who come to healthcare facilities to seek for what we call antenatal care. And when these mothers come, we usually test them for HIV, and those that we identify as HIV positive, we then follow them up in the PMTCT program. Basically just ensuring that we walk them through the journey of living positively with HIV, and also with particular interest to the child that they are carrying, the unborn baby, or even the baby that they are breastfeeding, for a period of 2 years, where we do a lot of interventions, such as ensuring that they are on ART, ensuring that they are on psychosocial support groups. We do case management, we do other interventions to just make sure that this mother walks the journey for 2 years and successfully have a HIV negative child. You find that as much as we want to have these women in the program for 2 years and even beyond, there are various factors that come into play, and for one reason or another, a mother will default treatment. And for this period that they interrupt treatment, then there's a chance that they will pass an infection to the child. And there are so many things that would lead them to have an interruption in treatment. Probably they have not disclosed the status, their HIV status to their sexual partners, their spouses probably, socioeconomic factors sometimes. as much as we have very many health facilities across the county, you still find there are women who cannot even afford transport to the health facility.
Kenya is a signatory to the Global Alliance to End Pediatric AIDS by 2030, but it has an ambitious plan to end AIDS among children by 2027 as it seeks to lower mother-to-child transmission rates from 8.6% to less than 5% as recommended by WHO. Building Waliaula, KTN News.